Good morning. Hello. It's my privilege to present our recent work in front of my dear professors and colleagues. Our topic is about semaglutide versus anti-hyperglycemic agents for type 2 diabetes. This is a presentation outline. As an introduction, according to the Lancet Journal and the Global Burden of Disease study, diabetes affect 451 million. طب السكرين باظ، معلش ممكن نبدأ من جديد. أنا آسف، في حاجة حصلت.
تمام يا دكتور، مفيش مشكلة.
I'm sorry. هو السكرين هو ظهر قدام حضرتك حاجة تليجرام أو كده؟
لا
دي مشكلة.
معايا تمام.
يعني حتى لو ظهر حاجة قدام حضرتك in diabetic patients. The prevalence increased in the last few decades, and it's expected to affect 9.9% of the world's population by 2045. According to the physiology of secreting insulin, glucagon-like peptide 1 is secreted from GIT, mainly from the enteroendocrine cells from small intestine, in response to nutrient stimuli, leading to insulin secretion. And this mechanism is blunted or even absent in diabetic patients. Despite the great diversity of type 2 diabetes mellitus medication, it is still challenging to achieve hemoglobin A1C targets in many individuals, and this is the main aim of the study. Regarding the physiology, as we already know, in type 2 diabetes, the insulin receptor defect lead to insulin resistance, and elevation of plasma glucose level is the key metabolic in the key metabolic tissues mainly. It's playing an important role in insulin signal transduction by insulin, which is fundamental cause of type 2 diabetes. Most of medication we use aim to maintain a satisfactory glycemic control. Regarding semaglutide, mainly, it was FDA approved as a GLP-1 receptor agonist for treating type 2 diabetes on December 2017. The structure of semaglutide resembled the glucagon-like peptide 1. Some modifications that made it suitable for once weekly use, reducing weight and lowering the cardiovascular risks. It showed also advantages with satisfactory safety profile and subcutaneous once weekly dose of 0.5 to 1 milligram. The rationale of our study, when we looked at the literature, we find that a lot of trials comparing semaglutide doses and other anti-hyperglycemic agents, including their different names, conflicting between each other, and the best management plan for type 2 diabetes therapy is not clearly identified. So we performed this study. We aim to design a network analysis aiming to evaluate the safety and the efficacy of different doses of semaglutide as a GLP-1 receptor agonist compared with anti-hyperglycemic agents with their different names for treating type 2 diabetes mainly. Regarding the methodology of our paper, we searched for databases including PubMed, Scopus, Web of Science, and Cochrane till December 2021 for relevant clinical article. The inclusion criteria was mainly the randomized clinical trial enrolling the patients type 2 diabetes, comparing semaglutide with other AHAs or placebo, and reporting safety and the efficacy outcomes. We excluded in vitro studies, overlapped databases, conference abstracts, and others. We aim to assess efficacy outcomes, including hemoglobin A1C level change and self-measuring blood glucose and the body weight change, the number of patients reaching hemoglobin A1C less than 7%, and the fasting blood glucose. Safety outcomes included overall adverse effects and the serious adverse effects and the gastrointestinal adverse effects, mainly including nausea, vomiting, and others. The results of our study, before presenting the results of our study, we will present the characteristics of the included studies. Sample sizes between studies ranged between 37 to 1,231 patients, and they compared semaglutide for different doses of semaglutide, including 3 milligram, 7, and 14 once daily, and subcutaneous also with doses of 0.5 and 1 milligram once weekly, and 0.05 and 0.1 milligram once daily, comparing with other AHAs. The final included studies were 25 trial. The follow-up periods ranged between 5 to 104 weeks, and the mean age ranged from 51 to 71 years. The mean duration of each trial ranged between 2 to 15 years, and the male representation was 35% to 90% in each study, and the hemoglobin A1C level, the base level, was 7.3% to 8.7. In our study, we aim to assess this item specifically if it became less than 7% or not. Our first outcome was the change in the hemoglobin A1C level. We performed two analysis models in each outcome, the network analysis and the ordinary analysis, meta-analysis, the ordinary. Network meta-analysis showed that tirzepatide has the highest reduction of the hemoglobin A1C level among the other AHAs compared with placebo at early follow-up and late also, including 4 weeks, 8 weeks, 12, 16, and 23. Subcutaneous semaglutide, mainly 1 milligram once weekly, had a comparable reduction of hemoglobin A1C level among other AHAs compared with placebo at 4 weeks early follow-up. Also, the oral semaglutide, 14 milligram once daily, had the highest reduction of hemoglobin A1C level among other AHAs compared with placebo at the late follow-up, including 20 weeks and 26, 32, and 40 weeks. Regarding the doses, we assessed the different doses of semaglutide via the meta-analysis, ordinary meta-analysis. The bold mean difference, or the bold analysis, showed that the semaglutide 1 milligram once weekly lowered hemoglobin A1C level more than semaglutide 0.5 milligram once weekly at the late follow-up, 55 to 65 weeks. Okay, this is the first block showing the results of hemoglobin A1C level. We will find that each figure contain the follow-up duration. This is 4 weeks, and this is 8 weeks, and 12, and 14, and 16. And we will find the effect of semaglutide increase with the increase of follow-up duration. This is the continuation of the file. Sorry. This is a continuation of the file, hemoglobin A1C reduction at 23 weeks and 26 and 30. And we will find the semaglutide give more effect with more follow-up duration. Okay. Our second outcome is the change of body weight. Also, the network analysis showed that tirzepatide, which is also a GLP-1 receptor agonist, had the highest body weight reduction among other AHAs compared with placebo at 4 and 8, 12, 16, and 23 weeks. Subcutaneous semaglutide 1 milligram once weekly had a comparable effect on the body weight reduction among the AHAs compared with placebo at 8 weeks. So the semaglutide 1 milligram obtained its effect in the early follow-up duration. Mainly, tirzepatide show the effect along the other follow-up durations, including 4 and 8 and the follow-up weeks. Oral semaglutide, 14 milligram once daily, had the highest body weight reduction among the studied anti-hyperglycemic agents compared with placebo at 14 weeks. And the canagliflozin, which is SGLT2 inhibitor, 300 milligram once daily, had the highest body weight reduction at the early follow-up duration, which is 4 weeks. Regarding the doses, subcutaneous semaglutide 1 milligram once weekly lowered the body weight more than the 0.5 milligram weekly at the 45 to 15 weeks. Our third outcome is the reduction of self-measuring blood glucose. The network analysis showed that oral semaglutide 14 milligram once daily was associated with more self-measuring blood glucose reduction than the 3 milligram oral semaglutide once daily at 26 weeks. Also, subcutaneous semaglutide 1 milligram weekly was associated with more self-measuring blood glucose reduction than placebo, and more than subcutaneous liraglutide, which is GLP-1 receptor agonist also, once daily. The network analysis showed that both results showed more self-measuring blood glucose reduction with the higher dose than the lower dose, as we saw in the previous analysis. Okay. The outcome 4 is the rate of reaching hemoglobin A1C level less than 7%. The network analysis showed that the bold results showed the oral semaglutide 14 milligram once daily had the highest rate of reaching hemoglobin A1C level less than 7% among the studies AHAs compared with placebo at 26 weeks. while subcutaneous tirzepatide, 15 milligram, had the highest rate compared with placebo at 30 to 40 weeks. However, non-significant increase was detected with oral semaglutide 7 milligram once daily compared with oral semaglutide 14 milligram once daily at the late follow-up 52 weeks. Okay, meta-analysis showed that higher rate of reaching hemoglobin A1C level also with the higher dose rather than the lower dose of 0.5 milligram. So the higher dose of 1 milligram is favorable across the whole outcomes. The outcome number 5 include overall adverse effects. We included overall, including the gastrointestinal and nausea, vomiting, diarrhea, and others. The network analysis showed that the rate of adverse events with oral semaglutide at different doses, 3 milligram and 7 and 14 milligram once daily, was similar to placebo at 26 weeks. Also at 30 to 40 weeks, adverse effects rate with subcutaneous liraglutide 1.2 milligram once daily and oral sitagliptin also 100 milligram once daily, and subcutaneous semaglutide 1 milligram once weekly was similar to placebo, while subcutaneous semaglutide 0.5 milligram once weekly as well as subcutaneous tirzepatide 10 milligram and 15 milligram and oral semaglutide 14 milligram once daily showed a higher risk of adverse events than placebo. We will talk about later in the conclusion of the study. The meta-analysis showed that both results showed a non-significant difference in adverse effects risk with subcutaneous semaglutide 1 milligram once weekly compared to placebo at 12 weeks with a risk ratio of 1.17. Also, no significant results was shown comparing the subcutaneous semaglutide with subcutaneous semaglutide either 1 milligram or 0.5 milligram at the late follow-up, 55 to 65 weeks. Okay. This is the first block of the network meta-analysis. We will find that this is the overall adverse effects. We will find that the most risk is in the oral at the 30 to 40 weeks. We will find that oral semaglutide 14 milligram has the highest risk between the other drugs, as well as in the 52 weeks. And this is regarding the adverse effects, gastrointestinal adverse effects. We will find that most of the drugs with their doses has a high risk of gastrointestinal adverse effects, mainly also semaglutide with other doses and liraglutide and other drugs, including 26 weeks and 30 to 40 and 52 weeks. What's the conclusion from all these numbers? The first conclusion is that semaglutide and tirzepatide had a favorable effect in treating type 2 diabetes according to the measured outcomes previously. Second conclusion, that they reduce hemoglobin A1C level and fasting blood glucose and self-measuring blood glucose and the body weight with no increase in adverse or hypoglycemic events at most doses. The third one is that gastrointestinal side effects were similar among the other included drugs, as we saw in the previous presentation. Also, one semaglutide, either oral or subcutaneous, followed by tirzepatide, both drugs, semaglutide and tirzepatide, recorded the highest risk of the gastrointestinal adverse effects. Most of the drugs, including semaglutide, tirzepatide, and the others. So the adverse effects were similar between all of them. Is that it? Oh, yes, thank you.